There are some people I want to thank. We must thank, we should thank, and we want to thank. And they are the program sponsors. Because the font is smaller than my eyes can adapt to, give me a second. And those people are the Cancer Institute of New Jersey, the New Jersey Commission on Cancer Research, of course, as co-hosts of this event, but also the partners American Cancer Society Eastern Division, Cancer Care of New Jersey, Gilders Club of Northern New Jersey, the Leukemia and Lymphoma Society of Northern New Jersey and of Southern New Jersey, New Jersey Department of Health and Senior Services, New Jersey Cancer Education and Early Detection Program, with both the Office of Cancer Control and Prevention and the Office of Cancer Epidemiology being a part. The Susan G. Komen for the Cure of Central and South Jersey, the Susan G. Komen for the Cure of Northern New Jersey. And I know much about the work that they do, and we won't speak of whether the title that they chose or is or isn't. Just for a moment, we'll put that to the side and recognize that they're here because they believe this work is important. And the Young Survival Coalition of Northern New Jersey. So a recognition to all who came together. In addition, there is a new group gathering. We've always been thinking in silos, or at least we've been thinking in silos for a while. The Breast Cancer Coalition and the Prostate Cancer Coalition and so on. And there's a group that said it's time for us, that important work actually happened and is ongoing. In addition, there's a need for us to be bigger, broader, more global in our thinking. And so there is a group that has come together, and I hope you saw their sheets out there, the United Voice of Cancer Advocates and Researchers, a very important new initiative. Judy Klein can certainly tell you more. Judy Klein is sitting right there. She will be the scribe. I won't even bother to give you the credentials and all the organizations she's belonged to on behalf of making sure we do the right thing. But I started to work with her in the very first breast center that I set up in 1983. And so our relationship goes back a long way, and know that she is a committed person. And so this initiative will happen, but it will happen only if we all sign and be a part of that. Additionally, as we go forward to focus, we're going to focus our dialogue on what are the gaps in each of the 6 domains that we spoke of here. You will have a choice. You can either come up to this microphone. If you do, then that is your signature, number 1, that you're allowing yourself to be on tape, because this tape will be broadly deployed. So that's one commitment. And also, Dr. Latimer will give you a paper to sign that you do agree to be photographed. You don't have to be, because Michael, sitting already with microphone in hand, will walk to any of you, and then only your voice will be heard, and your face will not be seen. So that's another way, 2 ways for you to be seen. I'm going to do something that's unorthodox with our panel, and that is to ask them to remember they're so used to, when they're sitting in this configuration, myself included, of treating this as a Q&A, as if one of us must comment once one of you makes a comment from the audience. So I will invite their comment at junctures where it might then add to, but we up here are so used to saying, yes, we do recognize the need for that service. And by the way, in my hospital, we actually have a new service that directs itself. We're so used to that. And so for this dialogue, we really need your voice most. So, to begin, the first issue that we talked about is the need for data. Now, perhaps that's not the easiest one in which you can identify gaps. We know that we have a great cancer registry in the state of New Jersey. Are there gaps? Are there ways that you've all been looking for that kind of information and you've not been able to assess it? Are there things that we should be thinking about in that domain? The domain of data and data availability. Any thoughts? Face the audience then, okay. If you're going to use that microphone.
Actually,
thank you.
My question is about data. When you say New Jersey, doctor, has a wonderful registry, but our pie charts and things compare us to other states. So how are those going to be accurate if, say, Virginia is not as diligent, or, you know, I'm not picking on Virginia, but I'm just giving that as an example. Is it a true, honest comparison then? And I guess I give that to you because you're our data expert.
And I'm going to stop Betsy from answering it for a moment. Because you see, not only are we so tempted to treat this as a Q&A, you're tempted to treat it as a Q&A because that's what you're used to when we're all sitting up here in that configuration. So Betsy, hold that question just for a minute. And because the microphone wasn't as close to one's mouth, it looks like I'm almost eating this microphone, as it needs to be. No, Fran, I did not tell people that, and it's not fair. I'm going to repeat the question. If we look at data, how do we know the validity of that data, the reliability of that data, if we don't know if every state is being as diligent as we are in submitting? Did I paraphrase that correctly? Okay, so one of the things that we may want to do, and one gap there may be, is, for instance, see how this sounds, in our understanding the National Cancer Database data, because we don't know, how can we be assured of the diligence of the information that's coming from other states as well? Would that be a fair reconfiguration of the gap based on the question? Anybody have a problem with that? Okay. Anything else on data? I didn't think data was going to be the place where you saw the most gaps. In truth, because the data is sort of like behind the scenes driving some of what we're recognizing has to be done.
So one of the areas that I think we do have to pay attention to is some of our outcomes, our clinical and treatment outcomes, and how they're affecting young adults with cancer, and also how to link those to perhaps some of the biological progress we're making to Betsy's data. And I think this particular group is really a good one. Because the numbers are reasonable. You've got a good time or a good chance of long survivorship, and you know, a long history of survivorship that we should really here in New Jersey start to think about how to do a better job of that and be a leader in that area.
Good point. Dr. Grant.
I guess I would say that I think there is. We have a lot of data on cancer recurrence from the registry. We have a lot of data on survival, but we don't have data on some of the late effects, some of the other issues that are pertinent to survivorship. And how do you do that? How do you build or add to the fields that we collect in cancer registry and make it a richer database that includes several of those things?
One of the things that we work on in PEDS is we have the Children's Oncology Group, and the Children's Oncology Group provides a wide database. Is there a way to start taking AYA and essentially make a consortium like the Children's Oncology Group, and then use that as in a preliminary way to start getting data?
So you're identifying gap/opportunity.
My thought would be to not only use tumor registries, but the existing databases and utilize it for purposes of research in terms of designing questionnaires that can be sent out to these young adults, asking them to be open, some open-ended questions, some pertinent questions about late effects, but asking them specific questions about what do they want to learn. We've talked about the fact we don't know what they need. This is the perfect opportunity to do research on that.
So I think I'm hearing a burgeoning theme that the kind of information that we need isn't necessarily hidden anywhere in the data, because we're not making sure that we capture that while we capture other data for the registry and other ways of gathering information and data. Did I miss somebody who wanted to speak to the data issue?
There you go.
Yes. And nice and close to the microphone, okay?
Okay. Hi, I wanted to address the data issue, and that when we talk about what's already out there, to latch on to what you said, we do have a lot of data, especially in New Jersey, and being in healthcare and being a woman and a minority, and I think that Dr. Gibbon touched on that. I think Matthew touched on that when they both said, Matthew, I'm too young for this. Dr. Gibbon, who said that there's a racial and ethnic problem that we have to deal with that we're not seeing. We do know, and one particular study by the University of Pittsburgh that says that African-American women who are diagnosed or presented with clinical symptoms are diagnosed at 29 days later than most other groups of people with breast cancer in particular. We are still less than 15% of the total population, and that echoes here in New Jersey, which is the most densely populated state, and yet we are dying more than any other group of people. So I think the types of data, we already have data, and we need to look at that and say, what are we doing with that? Because we also have data that says that our cancer, once diagnosed, is more aggressive. It's more aggressive than most other groups of people. So I think we need to take that, what we have, and act upon it, for example, and maybe lowering the age of mammographies and prostate exams for our black men. So I think that we need to consider those things that we already do have in New Jersey because we have a lot of information already. Thank you.
Thank you. So a part of the message here is having the data is one thing, partializing the data so it tells you what you really need to know about different groups, and then making sure the action plans that we set up are referencing that data that's there. So
Exactly. Yes.
I wanted to make sure I understood. On the business of data, I thought there was somebody over here that had, yes. Please come to the microphone and then please do talk close to the microphone.
Good afternoon. My name is Mary Lou Galantino. I'm a professor of physical therapy, and one of the areas that Dr. Grana eloquently pointed out was the issue of survivorship and rehabilitation. One of my areas of research as a postdoc fellow with the NIH in complementary alternative medicine is precisely the use of AYA use of various complementary therapies. I think that this is very important. I think it was alluded to in some of the discussants. However, I think we don't have data on that. What are AYAs using? Are they using herbs? And if so, is there an herb-drug interaction? What are the elements of the various complementary and alternative modalities that are out there that are germane to this population? I think that would be an area that I would love to see added to the list. Thank you.
Thank you. Any from the audience, the participants, and now I would invite the panel to make comments about where you think there are gaps.
I think that one of the themes that is coming up is really speaking to the fact of where do we obtain our data, and what databases do we use, and what can we, piece out or pull out from those databases to help us look at disparities between African American women or Caucasian women, to look at, why are the, patients being diagnosed with a higher incidence of, say, melanoma or a lower incidence of melanoma, and then utilizing that data to help us plan strategies and interventions to improve patient outcome. And I think, this is one of the major problems not only recognized in this country, but also in Europe, that there really doesn't exist a database that we can get every bit of information that we want. And there are multiple healthcare systems within the state of New Jersey that have patients that they are caring for. If you go, a lot of data that's utilized for epidemiological research sometimes uses the Medicare database, but this group of patients doesn't belong to the Medicare database. They are not always insured. So there isn't one database that we can go to try to piece out or figure out issues such as, was there a delay in diagnosis? What kind of treatment did they receive? Where did they receive their treatment? Who took care of these patients? Where did they go elsewhere? Did they have a second recurrence of cancer? And so speaking to the PRG, again, that is one of the first major goals that we really need to address, is how do we create a database in the state of New Jersey, or a data system, so that we can look and answer these questions. And then the second part that comes out of that is also specimen collection to help us understand the biology of what's occurring and what we can do or need to do to make improvements in care. And I think that they're intertwined.
Dr. Griffin, I'm going to ask you, I'm going to challenge you. How would you turn both of those into a 6-word gap?
Oh, that's a hard
one. I don't want to misquote you.
That's a hard one.
I think you're saying something important. What's the gap?
The gap is that currently there is not one database that allows, that's not 6 words.
You're close. Good.
There's not one database that allows us to get the information we need to answer all of these questions.
Okay.
And so the point is we need a central database specific to these questions that transcends all of the different healthcare systems in New Jersey.
Great.
And also allows us to have a central repository of tumor specimens and normal tissues, blood. No, I can't. You know me.
I got that.
Have you ever heard me use
But
7 words ever in my life? Never. My
but I've got
husband
it.
wishes I would only use 7
I've got
words.
it. That really did identify the gap. And yes, there's a few more words, but it identified the gap. Betsy, anything, a gap from, you're in the hot seat there, you're the one who's working with your team. What do you say the gap is from your vantage?
Well, is this on? I guess I would say that one of the things we have trouble with in this age group and also in the pediatric age group is long-term follow-up. Because it ends up being a very mobile population. People move out of New Jersey, and often females will change their names. So that poses a particular problem to us when we want to do survival on these populations. So any help anybody can offer us on tracking kids and young adults would be helpful. And I'd encourage you to use the registry as a comprehensive database, because we have a lot of information in there that is not tapped yet, and it has potential, but not the biospecimens.
So the gap then is in part on our using data that's available, and another is that we're not yet set so that we're able to do follow-up of the data.
No, we do some follow-up, but it's one of our weaker areas. It's easier to track people that have driver's licenses and things like that. And another area that needs work in this age group is complete treatment data.
I hear.
I'm listening, and I think also we have to figure out a way to communicate this to the patients. I think one of the problems that always happens, or at least the PRG pointed out, is that we lose track of young adults and adolescents because they don't have a buy-in to being part of this. I mean, we don't have the data partially because we don't collect it and we don't know where to find it, but also that young adults change their names, they move, they reintegrate into the community, they want to leave cancer behind, they're done. So how do we as professionals explain why this is important in a way that's succinct and clear and young adult appropriate language? I mean, to get it. We all sit here as professionals and we hear this in a professional language lingo, but how do you say that to a 25-year-old who's sitting down in front, or an 18-year-old who doesn't want to listen to this? How do you communicate how important it really is for the bigger issues at hand?
Communication gap, okay? And one more comment, sorry, 2 more comments, one from the audience and one from the panel on this topic before we move on to the 5 other topics we must cover. Go ahead, Matthew.
I was just going to say really, is this on? Hello? Okay. That in the world of advertising and marketing, where I come from, we call this a rule of engagement, or the point of impression. And how do you make it hip for them to care? What you're really describing is a very generational, out-of-the-box understanding of data collection, which has never, it's unprecedented. There's never been any paradigm to suggest that this was important up until like today, literally. So I think one of the reasons why what I'm trying to do is working very well is because I'm meeting them where they're at, which is online, which is socially networking, which is behaving in the way that they would normally behave. Just take cancer out of the equation, and they're just regular 26-year-olds. They just happen to have this common thread. So if there's anything that can be interjected into this new model and what needs to be built, and what Julie is very aware of and articulated so clearly, is how do we make it hip? How do we make it cool? How do you make your healthcare cool? And that's a very rhetorical question at this point, because the answers are resounding God knows how. There's no way to really do that to make your healthcare cool. If anything, Lance made cancer kind of cool, but you know, at this point, it's you know, they move on. I know lots of people that they cry in the shower. I know that lots of people, they start foundations, but most of the people just say, this is 5 years ago. I'm married now. I got a house. I got a kids. I want to just live my life.
So the gap then is that we don't make the need that we have for data something that engages the person to want to provide it. You're going to hear I'm going to keep paraphrasing back into the gap because we're here to identify the gap so that we can then put action plans connected to them. And I promised one more comment on this topic before we move to the next. Close to your mouth, very close.
Hi. I was just saying I was treated out of state, but I'm sent a yearly follow-up, a long-term follow-up survey, which I find very helpful because they send back the previous year's results and a lot of the comments that people put in. So you sort of get that, you know, universal, you're not alone in this. I was also thinking, though, that people, you know, as a young adult cancer survivor myself, I know that, you know, the mail is hard, but email, you know, that's, 20 times a day. And that's something that doesn't change, you know, even when you're married. Like, I still have my maiden name on my email. And, you know, between addresses and whatnot. And perhaps also, you know, with this sort of generation, if you could even tie it in with some sort of sponsor and do some sort of, you know, incentivize them. You know, if you complete it, you have a 1 in 100 chance of, you know, winning $50 iTunes credit, you know, but something like that. And you could very easily partner with people that would, you know, donate that. So I think that, you know, sort of like exactly what Matthew was saying, but tapping into these ideas, you know, to engage these people. And then, you know, perhaps also showing them the results, you know, after they take the study, you know, a month or whatever. I know research takes longer than that. You know, a year, you know, well, whatever it is. A couple months later, you email them the results, and then, you know, and then maybe if you've tied into another way, and these are things you could do about that. You know, take these questions to your doctor. You know, participate in this, and just keep it as part of the process instead of a one-time deal.
As part of a dialogue, I've been trying to conceptualize in my mind sort of a self-reporting website where people could go on and say, yeah, I'm still here, I'm doing fine. Do you think that would go over? Do you think that would be popular? Yeah?
I'm a survivor, but I'm not going to sit down and, like you said, like, mail it into everybody. But I love to be online, so take a few minutes. How you doing? Kind of a survey.
Okay, great. All right, thanks.
Thank you all for your comments on this topic. We're going to move ahead because we have really to identify gaps in each of the topics that we covered. 1, 2? Okay. Oh, it's on and off? All right, so to move to the next topic. I talk like this all the time. Yes? 1, 2. And so, we'll move on to talk about clinical care and research gaps from your points of view. Gaps. We know there's some great services. Where are the gaps? Clinical research, treatment, clinical services, access to clinical services, access to research, from any direction you want to come in. So everybody in this room found finding about research trials was pretty easy, and getting onto a trial was pretty easy, and finding a trial. I'm just checking out to make sure. If there's no gaps, then that's wonderful. Found it easy to get it on a trial. Find it easy to find out one that was relevant to you and your circumstance. Found it easy to find the clinical service that you needed, the treatment team that you needed. Wow.
Hi, my cousin was diagnosed with breast cancer at 39, had a double mastectomy. Not easy for me to talk about. So, and now has a chronic case of lymphedema, and is extremely angry about the fact that she can't get help. Someone suggested I pushed her to go to Sloan Kettering. She lives in Queens. And she's an RD, works in the hospital system. She's very educated in healthcare and is still really suffering from lymphedema, and I've been trying to help her out with looking into research and just the healthcare system, and I'm finding a huge gap in terms of lymphedema and research that's being done, and just the fact that, I can't remember which panelist spoke about how, you know, when you're in cancer treatment, you get all this care, and then suddenly you're a survivor, and it just drops. And my cousin, I heard her time and time again speak about this issue, and I think it's a huge problem, especially with her case with breast cancer and lymphedema.
So if I can try and paraphrase that, in this case, lymphedema is the example, but perhaps it's even broader, that other symptom management, post-immediate acute treatment, may not be as accessible as we would wish. Others on that? Yes.
Barbara, as you said, you asked the question, did people find it easy or appropriate to find trials and the like? Sort of a corollary of that is, did you go looking for trials? Because if you look at the relative numbers of people who end up on clinical trials, it's very small. And so were they available is one question, but the second question is, were you open, or were the people open to trials, and did you go hunting for trials? And I'd be curious to what people thought about that.
Well, that's an interesting one, because then if I had to try to reframe that into a gap, then maybe I'd say, is there a gap in educating people about their own independence and autonomy in being able to reach out and understand why they would want to reach out to find out about a clinical trial? Would that be a fair paraphrasing of the gap? In a second, Kath.
I'm not going to answer your question, but address gap in a different way. And I am a healthcare professional, but I'm really standing here as a friend and a family member. And I think that there's probably a lot of people in the audience that can relate to this, that very oftentimes, because people know you work in the field, your neighbors, the soccer coach, your son's mother, your son's friend's mother calls you and says, hi. And I'm reminded of a telephone call I got from one of my girlfriends about 3 years ago saying, hi, I'm calling you at work. And it was really unusual. And she said, I'd like to be making a play date for our boys, but I was just diagnosed with stage 3 breast cancer. And I don't know what to do. And so I'd like to address sort of the issue that what happens, I think, for a lot of people is that they turn to somebody they know, or they get referred to you. But what my friend says to me over and over and over again, and I think we've heard it as healthcare professionals, but as really in our role as humans in the communities that we live, what would I do if I didn't have you, because this healthcare system is so incredibly difficult to access? What would I know the difference between a community hospital and a teaching hospital? What would I know the difference between a clinical trial and a standard treatment? So I think that there's huge pieces, and it comes to a lot of us, and then of course then we're wearing two hats when it's coming, because it's our peers and it's our friends and it's our loved ones, it's our cousins, etc. But I do think that there's a huge gap, and then it falls over also then in terms of clinical trials.
Here, I promised Dr. Neville she could make a comment.
Yeah, well, I have two, but I'll keep it to one. One of the things that I think is so paramount, and I did not read in this report, is that there exists tremendous variability in what people want to know. So while I read that people lack the essential knowledge to really understand their disease and treatment, my research and the research that I've read of others has shown that there's a fair amount of people that really choose not to know. Simply not knowing is better than knowing, and they leave it to the healthcare professional or a colleague or a neighbor, and they'll run it by them, and once satisfied, they will do much better without that information. And that's not the way that I was educated. I was educated to, it would not be the way that I would want to operate, but I firmly believe that health professionals must assess the level of information sought by patients and family. And lots of times, what patients and families desire are incongruent, and you have to learn to deal with that. So I'm not sure I wholeheartedly believe that universally people are not getting the information. I'm sure it exists, but I think that there's a fair amount of people, the information is just too stressful and frightening, so they're better off not knowing, and that's how they operate.
So if I try and turn that into a gap, would the gap then be that the professional community doesn't always recognize that continuum from blunters to monitors and mirror their information sharing to the patient to what they're learning about that individual sitting in front of them? So if that's a service issue, maybe it's about recognizing, and that's the gap.
Right.
Again, with apologies to all of you that I keep reframing these into gap language.
I think your reframing is a great idea. I don't know how to put that up there, but my Italian wants to come out in my hands, so there you go. Okay. I've done pediatric oncology most of my nursing career, and I have participated in the pediatric oncology group that then merged, and we became the children's oncology group. Since the 60s, we have organized clinical trials that have been nationally recognized, and all of the institutions that belong to the CG participate in the same studies. And so we are organized. Most of our families, I believe, do get introduced to the concept of clinical trials. It is during a time when there is major crisis going on, and informed consent is always questionable, but they are always left with the option of, if you decide in the next 3 days you don't want to do it this way, it's fine. So we've kind of covered our bases that way. I don't think the adult world is set up that way. The oncology practices that I understand about the adult world are small practices, and not part of any kind of a collaborative effort across the nation. And so I think that lends itself to a huge gap in certainly the young adult population, perhaps not so much in the adolescent population, which is part of the group that we serve. And I guess that's kind of it. So just an organizational methodology for sharing.
A gap of collaboration.
Collaboration, yeah.
A gap, right. I hear that. I hear that.